Thank you very much, and welcome everybody to the autumn board meeting of Healthwatch West Berkshire. I think this is the 6th virtual meeting we've had. I thought we might have been back to meeting together this time, but that is for the future. So once again, welcome, and we will just have a quick whiz round for people to introduce themselves, the board members. So I'll look at my pictures. Adrian?
Adrian Barker, board member, as Andrew said, chair of the Forum for Patient Participation Groups and patient leader at the Royal Berks.
Karen? You're muted, Karen.
Is that all right? Can you hear me?
Fine.
Right. Okay. I do various things for the Academic Health Science Network in Oxford, and I'm a board member here.
Andrew?
Andrew Sharp, Chief Officer, Healthwatch West Berks.
Alice?
Good morning, everyone. I'm Alice Clifton, the Development Officer for Healthwatch.
Leslie?
Hi, I'm Leslie Wyman and I'm a board member for Healthwatch.
Nathan?
Good morning, everyone. I'm Nathan Pope, Digital and Social Media Officer for Healthwatch West Berkshire. And
I think so. We are at the minute missing one or two board members, but we'll come on to that in a moment. So can I extend a big welcome to James Lawrence Parr, who is going to give a presentation about the development plans for Hampshire Healthcare Foundation Trust, or redevelopment plans. We tried to have this last meeting for those who were with us, but technology proved a little too difficult to overcome. So this time we're using Teams, and hopefully things will go swimmingly. We will allow questions at the end of your presentation, James, if you're willing to take any. But in terms of the board meeting, I'll only take questions from anybody at the end of the meeting. So James, thank you very much for coming, and over to you.
Thank you very much, and thank you very much for the opportunity to share some of this information and talk with you. So as introduced, James Lawrence Parr, part of what we call the Modernising Hospitals and Health Services programme, which is in North and Mid Hampshire. And is part of the National Hospitals programmes of the 40 new hospitals. So we've been working on this programme for 2 years, and I think we have shared some information previously with some of your members in terms of our developments and part of our engagement process as enabling sort of organisations, and we're keen to continue to do that. So I'm going to just run through where we are, but also some of the context in terms of we've gone a little quiet recently, and that's because we're doing a lot more work with the National Hospitals programme, and I'm sure you're aware of your local programmes as well, that there's a real drive to make sure that wherever possible, learning from the National Hospitals programme is applied to all of the programmes, rather than, I guess, 40 individual programmes, and that's part of the remit of that new National Hospitals programme. So as I said, we're part of the Hampshire Together scheme is one of 40 new hospitals the government is committed to build by 2030. Currently, we're on a timeline for refurbishment and construction for 2025 to 2030. So we've got a 5-year window, and that's where we are aiming to be. And that is, again, with constant dialogue with local, regional and national colleagues. The money for a potential new hospital, so I guess Treasury, NHS gives some clarity as to what the purpose of the money is for. So it's for a potential new hospital, as well as significant investment into Royal Hampshire County Hospital in Winchester. So just again for people, we've got Basingstoke North Hampshire Hospital and Winchester Hospital and Andover War Memorial Hospital. That's the entirety of Hampshire Hospitals Foundation Trust. The money is for potential new hospital and significant investment in Royal Hampshire County Hospital. Clearly, this is a massive opportunity also for our broader system, so our general practice, community health, voluntary sector. So there's huge potential in terms of really transforming the system. So it's become quite a really useful conduit as to if we need to have a potential new hospital in 2025, then clearly the rest of the system and services also need to be in a really good place to make sure that that is sustainable and viable. Just galvanizing some really good conversations and thoughts about how we might approach that. We've been given £5 million in seed funding to develop a plan that would deliver for everyone. So that's really about developing a pre-consultation business case. So there's a lot of engagement that goes into that. And then once we get a pre-consultation business case, and we also get the go-ahead from our regulators, then we could move into the consultation process. And there's a lot of planning going on behind the scenes so that we're ready for that as well. And we're really keen to have a rich consultation and recognise that we've got many different populations and protected characteristics within our population. So that's going to be a key part of our future work that we're planning for. Excuse me. So in 2020, we conducted a listening exercise, and that's the bit I think that some of the colleagues on the screen were involved in. That included engagement with public staff and stakeholders, and was really fascinating to begin to understand our populations in more detail than I think we've ever done before, and really try and find individual protected characteristic groups and just get that broader understanding. We continue to work with patients, carers, clinicians, other NHS staff and local organisations. So we have patient reps on all of our groups, local authorities, a whole range of people, and can constantly involve them in things like our options development and options appraisal process. So how we go from a very broad idea into something that's just a little bit more refined as part of the consultation process. We've also completed an integrated impact assessment, and I'm going to come back to that in a second. We got to a stage, I think a few months ago, really, where we felt we were ready in terms of our pre-consultation business case. And that's when the new National Hospitals Programme really began to ramp up. And I think quite rightly wanted to make sure that there was some commonality of process across all 40 hospitals. And also, I guess, best use of taxpayers' money. So some of the work that we're now doing is working with those colleagues to see whether we can refine our model more, which again, I think you'll be aware of in terms of some of the media, Health Service Journal, those in terms of all of the programmes are just being sense checked to make sure that they absolutely deliver the highest clinical standards, but also in the most efficient and effective way. So some of our work has been paused whilst we go through that and really go through in detail whether there's anything we particularly missed at this particular stage. So when I talk about things like integrated impact assessments, we have done that. That is an assessment of health inequalities, quality, travel, and also environmental impacts. And once we had that, or actually during that stage, that's when we also reached out to colleagues such as Royal Berkshire, Salisbury, Southampton Hospital, Frimley, the network, stroke networks, a huge range of people. And there's also a whole range of commissioners. So we commission health services, but then there's also regional that commission different health services. So it becomes quite a complicated network of people. And in that process, it's also making sure that things like oversight and scrutiny committees are in place and joint commissioning committees. So a lot of work to say, if we do this, we think there might be an impact, but it is a modelled, unmitigated impact at this particular stage. And therefore, as we move through the consultation process and get a refined model, we would like to work with all of you to understand, one, how we can mitigate that, and two, if there's any opportunities to work more collaboratively together as part of that solution. So what we're going to have to do is, we're going to have to revisit some of these bits of work that we've done. So as the work with the National Hospitals Programmes means that we refine, I guess, essentially our capital envelope, that means that we're beginning to look at the sort of options that we developed. So we are anticipating that we'll rerun those again and obviously include the relevant people and engagement as part of that. Our ambition still remains the same though, and that's to really create 2 centres of excellence for everyone in North and Mid Hampshire. North and Mid Hampshire just is, I guess, in terms of Basingstoke, Winchester and sort of surrounding areas, and over at Bolton. So it's an interesting area in terms of the mix of rurality and conurbations, and it's interesting in terms of particularly because of that, things like digital exclusion and how we begin to understand that and mitigate that. Our engagement today has been quite fascinating. We've had a lot of feedback that actually the virtual platform has enabled us to reach probably more people in some way, has enabled us to, or people to be able to respond not only through chat bars or different mechanisms. So there's lots of positives, but we're not confidently saying we've reached everybody. So it's again something we need to look at and make sure that we continue to do that. The 2 centres of excellence that I mentioned, one would deliver specialist emergency care, the other would provide planned operations and procedures. And as with other programmes, we'd like both centres to be recognised for outstanding quality of care. We'd like to really be able to attract and retain expert staff, provide training for the next generation of doctors, nurses, health professionals, and the right environment for research and innovation. So some of the talk about is about the health campus, where you then are able to develop some of that infrastructure around it and really involve the community in part of that in a whole way. At the same time, even though I sort of mentioned different specialisms, both of the hospital centres would continue to provide most common need day-to-day routine hospital services for local people. So that means for most services, most of the time people continue to use their local hospital. That's still our ambition. Some of the work we've done will still be maintained as well. So in terms of site selection, so again, there was a very detailed, long process. So stage 1 of site selection, so actually where a potential new hospital could be, covering entire Hampshire Hospital's catchment area for sites measuring 40 to 50 hectares. So that would allow for a sort of health campus development. So 9 sites were identified, including Basingstoke, Winchester, Mitchell-Dever, Sutton, Scotland and Andover. We then went into a stage 2 where we ranked all of those according to 36 weighted selection criteria, including planning, environmental, transport factors, and had a top 5. And then into stage 3, which is land availability investigation. So that's contacting the owners, willingness to sell, potential price, timescales, availability, and a further 4 options were discounted as part of that process. So we ended up with 2 really sites. One is land near to junction 7 of the M3, which is close to major road links and central to geography. But if I come back to the bit about what we'd like to do is centralise some services and invest in Winchester, the bit I was talking about in terms of what impact does that have on our populations and also the populations of other people that go currently to different services, acute trust, community health and social care services. And that's the bit that we, again, will come back around and make sure we understand the high level impact, but then continue to engage with people to say, we think there might be this impact. And it could be an inflow or an outflow. And the key bit about this is if we understand that even at a high level, and we've really had some good conversations, then when we get to a consultation process, we can also tailor our consultation to local populations about how they might want to utilise services that we can also share with partners as well to make sure we get some good solutions in place. We're really mindful that ultimately what we'd like to do is to maintain the patient population that we have. This is not about destabilizing any partners or networks, but it is about having the conversation so that people are informed and can join what we're doing and contribute wholly to that. So that's the land near to Junction 7 and M3 is one site. The other site is the current site of Basingstoke and North Hampshire Hospital. As you get into more sort of detail, lots of other factors become involved. So I mentioned that we also looked at the sort of the environmental impact, and that would also include, you know, if it was a Basingstoke and North Hampshire Hospital, then decanting and recanting services and potential demolition also has some environmental aspects as well. So there's quite a lot of detailed work going on in the background. So that's where we are at the moment. We've got some ideas as to the model. We've got some understanding at the moment as to what the impact is. We're working with the National Hospitals Programme to further refine that and also clarify really what's the gateway for us to then go into a consultation period, which at this stage isn't confirmed. I guess as we get a bit more information from our work with the National Hospitals Programme, we're very keen to keep engaging with people, including yourselves and commissioners and providers of any potential impact and opportunities there might be. I'm going to pause there. I've taken a lot of your time.
Well, thank you, James. That's very interesting. I must confess I have been impressed generally with the Hampshire Together programme in the way that you have actually had quite open visual meetings with a variety of people. And I think that's very useful for those interested in actually seeing what's going on. So is anyone got a question for James at this point? Leslie?
Yes, just a quick one. You mentioned the environmental impact of using the current site at Basingstoke Hospital. I wondered if any environmental impact of choosing the other site had come up, whether you'd come across anything in doing an environment impact on that one.
Yes, it's quite interesting. So again, at a fairly high level, if we look at the environmental aspects at the moment, so where, I don't know whether you know where Winchester Hospital is, busy road, a lot of pollution. So we have that odd situation of a hospital being in an environment that isn't ideal, and probably the travel that goes in and out of it contributes to that as well. But then if we move services or centralise services, there could be impact in terms of greenhouse gases and a whole range of other things on different populations. So again, we've got a high level understanding. We'd need to get into more detail, but again, it's another point we need to engage with people as to what does this mean? How does this fit with sort of local authority or county council plans? We've also got some fascinating work with the European Space Agency, who I think were supporting some of the 40 new hospitals programs in terms of what innovation they can bring. So how can I use data information that we don't have, so space, air, all sorts of things, into our understanding, and also longer term into helping to inform our people about things that might exacerbate their condition so that they are in the best place to begin to help themselves as well. So there's some really fascinating things coming from it. So I'm not sure I entirely answer the questions. We have an understanding as to what some of those environmental impacts are at this stage, but it's a little bit of a moving piece. And again, it's something we're going to have to revisit to be clear. And then again, after consultation, when we then have gathered all the information, analysed it and come up with a more concrete plan that we move into a different business case, again, we continue to understand what those impacts are.
Sure, thank you.
Andrew?
Thanks, Mike. James, thanks for the presentation. That was really, really interesting. I mean, I like Mike, have been hugely impressed with the whole Hampshire Together programme in terms of the engagement, especially when you just remember, oh, by the way, there was a pandemic on. The digital exclusion piece that you mentioned is still key, and you know, it's still something that we're just generally worried by, because digital for people who find it easy is easy, and digital for people who don't is a foreign language and unaccessible. So we've got to be careful with that. I've got three very, very quick questions, hopefully. There appeared to be some sort of issue with West Berkshire Council properly engaging with your scrutiny board some time ago. Have we now sort of got proper working, healthy relations with West Berkshire Council, in your opinion?
Yes, I think we managed to move that forward. I think there was also a change of personnel as well. And again, it's another thing we've got to revisit in terms of the Joint Oversight and Scrutiny Committee. So I think there was a representative who joined the meeting, but more to observe at that particular stage to help their decision-making process as to their best route for engaging in that particular process.
Fabulous. And secondly, and this is more for sort of general information, because I'm not completely clear and just want to try and increase the knowledge. If you went for the M3 site, we are still saying that the Basingstoke site would still operate in one form or another as a medical facility, aren't we? Or aren't we sure?
No, so in the options we currently have at the moment, we would either have a centralised hospital that resides at the Junction 7 M3 and more investment into Winchester, or at the Basingstoke site and invest in more into Winchester. That's why the bit around modelled, potentially unmitigated, becomes quite key, because clearly there's a whole range of services, urgent and emergency care type services in the Basingstoke area that would need to be considered and are utilised by people outside of the North and Mid or Hampshire county boundary, which is why it becomes quite key.
Okay, that's really helpful, because I wasn't entirely clear, so it's good to know. And then thirdly, and I asked the Royal Berks Hospital programme exactly the same question about this campus style solution, is do you foresee this including the sort of mental health side of things? Because in all of this hospital building programme, and I raised this at a previous meeting, all the attention is on physical acute and what have you, and sadly mental health seems to be coming off as the Cinderella again. No one's talking about building, new mental health hospitals or units or things like this, and I don't know whether that's an assumption, or can we genuinely look at this being a holistic person 21st century hospital, so we're not even separating them, and it would of course be part of it, or is it something you're still looking at? Thanks.
It is absolutely included in all the conversations. It hasn't been separated, and mental health is quite key. It's also a dominant feature so we're part of the population health management, so new patient linked data, the health intent platform, and one of the key pieces of work that we just picked up is mental health alongside sort of additional investment to co-design services. So that's part of, earlier I was indicating the hospital has triggered a whole range of other things that are now beginning to move forward. So the design of some of those services are sitting in other programmes, but the governance across North and Mid is linking more and more effectively to say it is one large programme. At the centre of it, we need to have a common reference point to make sure that we're delivering everything, and we're not separating mental health out at all. In fact, a lot of our transformation pillars, where we had a transformation pillar about mental health, is now mental health features in all of the other transformation pillars. So let's not call it something else. It's just how we meet population needs. So it is, and it's actually not excluded.
Thank you, James. Adrian?
Yes, thanks guys, really interesting presentation. One of the key things that will influence your options, presumably, is how much money you've got. Do you have any idea what the envelope is? And if not, when are you likely to find out?
It's a good question. So we had an indicative amount at the beginning of the programme, lots of conversations saying it was an iterative space and we have to meet clinical standards. The more recent approach and conversations with the National Hospitals Programme, and I guess COVID and the money that's been spent probably in the NHS and Treasury battling with those sorts of things has some influence. It means that I think a number of the 40 programmes are being asked to really consider the initial indicative budgets rather than some of them had grown quite a lot. Plus, there's also, I think, a really new way of looking at things. So we hear a lot of things, and it's a bit technical jargon about modern methods of construction. So we look at Cardiff recently. I think they built a number of beds for a relatively small amount, which is sort of prefabricated. So we look at a hospital, some of it will have to be very specialist. And then other areas have to be less specialist, and then certainly some of the back office function could be delivered in a whole different way. So we really look at it that way. There are some efficiencies that could be made. And the key thing is, and this is where we're getting a lot of case studies and evidence base is the totality of a health and social care system that really is important in terms of if we only want the people to go to specialist hospitals that need to be there, but we've got good provision elsewhere, then that also has quite an impact on the size and therefore the capital cost. The other thing, I guess, is the revenue part as well. So we've also got to make sure that collectively we can afford and provide quality services for the whole of our population and do the transformation in our sort of out of hospital piece as well. So it's quite a juggling act. We are being encouraged to so nationally, the national programme has asked all the programmes to really do more work on the indicative budget option, plus also the preferred option. And then I think they're going to look at the kind of delta between the two, and we continue the conversations as to what the resulting model would be at the pre-consultation business case sort of level. So it's not fully detailed. So our indicative budget, I think, is about 550 million. We have a challenge in terms of the seed funding I mentioned earlier comes out of that. So the longer that we continue the sort of work up, the more we eat into our own budget. But that is just part of sort of NHS and Treasury process.
Thank you. And could I welcome board member Amanda Cunnington? Welcome, Amanda, who has a question.
Yeah, very, very sorry I was late. I'm really, really interested in the work that you've been doing, and it sounds like it's been really well considered. I guess I was thinking about the two things really. One, but I think the main one was the funding. Obviously, I saw yesterday in the HSJ there was another kind of 14 days to bid for 500. I can't remember how much it was. I think it was quite a significant amount. What is it here? 700 million fund for the ICSs, for capital and other projects, tech projects really. And I was kind of just interested in how are you managing to take advantage of all the kind of short-term things that are around for the next 2 years for trying to kind of make sure that the COVID recovery is as good as it can be, which are capital expenditure as well, while also having this bigger kind of programme of making sure you're kind of going in the right direction long term for the site of the hospitals for North Hampshire, because it must be very tricky to be bidding for things in the short term when actually you're also making these really big strategic decisions in the long term.
Yes, it is challenging, and I guess the emergence of integrated care system and us really working together is helping. So it's about joining up the conversations in terms of who's bidding for what, and can we be more coherent in terms of what our plan is and what are our priorities. So there's some helpful conversations emerging from that point of view, and that includes sort of other capital as well as things like sort of Section 106. So in development, some of the monies that's sort of allocated towards health. So how do we use that coherently is an emerging conversation, which is really great. But it is, and I guess the other thing is how we structure a range of parallel programs. So business case for a new hospital, potential new hospital, but also if we had a case for our out of hospital, that's not the right terminology, but I always struggle with community is digital. You know, if you begin to line up a few and say, okay, by 2025 to 2030, we are going to start laying some bricks or whatever material it is for a new hospital, we need to be in a fundamentally different place. So if we have those approaches all lined up, so that I guess also the decision makers, so governing bodies and those sorts, can see the totality of the whole in terms of capital, revenue, risk, all sorts of things, that also helps the coherence of conversation and galvanizing multiple organizations into a single direction. So that's where we're beginning to go at the moment as well, which is helpful.
My second thought was really quickly, just that I guess coming at it from a patient perspective, that sort of population that live towards the south of Newbury absolutely do go in that direction, and I think it's just really, really key. They are represented properly in this in this consideration, because you know Newbury's in a really weird place, isn't it, where it's kind of not close to Reading, Basingstoke, or Swindon. And therefore the choices are going to really impact the people who are living on the south side.
Yeah, but very quickly if I could answer that. So what we've done in terms of, we've done high level, what we think an impact might be in terms of where people travel either by quickest time, and even with the sort of ambulance services, you know, what does that mean in terms of performance and quality and all sorts of things. What we've identified quite quickly is there are different populations who travel in different directions for most likely different reasons. Sometimes it's a county boundary, sometimes it's arterial roads. And then when we've spoken to a lot of colleagues who've done this in depth and then said, and when we opened the new hospital, what we predicted didn't happen. It was because people could drive up the motorway and park at this new shiny hospital, and it took a few years to settle down. So we will endeavour to do the very best. The bit I mentioned earlier is, if in that process those sorts of populations are where we can also focus our consultation and really understand how people might want to utilise services, and then link in with other commissioners and providers as part of that process to work out what a solution could look like.
Thank you.
Thank you, Karen.
Yes, back to funding. Is it all state funding, or is there any charitable funding that's being tapped into? I mean, one could see that there may be people who would like, for example, to sponsor a ward in the name and in their name or something.
That's a very interesting thought. I'm not sure it's one that's being wholly considered, but I can certainly take it back into the programme. I think it is different routes of funding are considered. So underneath this, there is something called the Green Book process, which is a Treasury process. And part of that process in terms of options development and options appraisal is you really have to consider all sorts of funding routes. But I'm not entirely sure that what you suggested has been to enough degree, so I'll take that back. So that's really helpful. Thank you.
Well, thank you very much, James, for both your presentation and actually for answering the barrage of questions that we put to you this morning. We are now much better informed, and once again, thank you for coming, and I'm pleased that technology actually worked this time.
Pleasure. Thank you. Thank you very much.
Thanks, James.
Thank you. Bye.
Thank you. Bye-bye.
Right, we will move on to item 2 on the agenda. Apologies for absence. I think that's Martha Vickers and Paul Wilson. Am I right?
I think so, yes.
And are there any new declarations of interest that we haven't covered in previous meetings? No? Fine, thank you very much. We'll move on to the minutes of the last meeting. Does anyone have any amendments? No? Then we'll take those as being correct. Thank you very much. And move on to, are there any matters arising that aren't covered on the action log, by the way? Okay, we'll move on to the action log, the latest version of which we had yesterday. The first item ongoing is item 9A from March. Contact and issues report on thinking together. How is that going? Who is able to answer that? Michelle or Adrian?
Well, it went back to the Mental Health Action Group, as the minutes say, and the members of the group were given, I think, a couple of weeks to come back with responses, which were coming back to Andrew. And I don't think you've had very much, have you? So
no, we haven't really had any. So effectively, the report is ready to go. So we've just got to slot it in with the various other work we're doing to actually get it launched.
Fine, thank you. And the next item, number 10 from that same meeting. This is the voice of disability, which Paul would have answered to, but he's not here. Are we able to say anything, Andrew?
Yeah, I've had some long conversations with Paul, and also a brief one with the former chief officer of West Berkshire Council. So we're going to move the response to VOD back to the second quarter of 2022, because we've got lots of people in the disabled sector who've been shielding. So actually getting meaningful feedback is and remains challenging. And what we don't want to do, frankly, is mess the opportunity up to re-present the recommendations and what has or hasn't happened to the Health and Wellbeing Board, because I think both Paul and myself still very much feel that despite what was said when it was presented at the Health and Wellbeing Board about disability issues cutting through every piece of council, ICS and ICP strategy, in reality we don't see a great deal of that. And probably what the board needs to do is read the report, see if the recommendations sit, because we still think proper focus needs to be given, and the recommendation about perhaps a subgroup of Health and Wellbeing Board might be the answer, but we'll take that back to them. So that's where we are with VOD at the moment.
Well, thank you very much. So that's still ongoing. And the quality framework, item 8A.
That has somewhat slipped down the agenda with the huge amount of workload. Fortunately, I think it has for every other Healthwatch. So Healthwatch England is still keen that everybody gets this done by 2023. I think we'll be realistically looking at this in 2022.
Excellent, thank you very much. And the next ongoing item is item 9B, community engagement. Is Michelle able to speak to that, or are you doing that, Andrew?
No, that's fine. I can just quick, as we updated on the action log, once the report's been published, we can then look at starting some kind of focus group for it.
Fine, thank you very much. And the only other ongoing item which is open is 9C, community engagement for carers. How is that going? Alice, Adrian? Michelle?
I think that's ongoing at the moment. And as Andrew said, that's slow at the moment, but we are still doing it. So,
how big a response from the carers do we need?
I would say at the moment it's not been fantastic, so we still have to go back, and I would at least, even if we get about 10 people, would be good.
I see. Okay.
I don't think it's going desperately well, Mike.
No.
And
so
also,
I think we need to do some work on it.
And also, they are not meeting face to face either, so it's not been easy.
Yeah, I understand. Okay, fine. Thank you. Well, that is all, I think, the items on the action log, so we can move forward to the Chief Officer's report, item 4. Andrew?
I'm going to keep this brief because obviously James's presentation somewhat overran, but I absolutely think it was worthwhile. So I think, we should make the most of getting access to information that may not be as accessible to everybody. So I'm actually quite pleased that he was able to answer lots of questions and give us so much detail. In terms of, we haven't received any particular complaints, and I suppose in terms of what has changed, the Health and Scrutiny Board has now met. We were invited to it. We will continue to be an active member of it. There is also some movement on learnings from COVID and the COVID report, so we'll come back to you on that, but that does seem to be a thing. We did get a commitment that the COVID report would be followed up, and I think that may well happen, but we equally have to make sure it does happen. And I think that's all I want to say, because I think the rest of the agenda will cover off everything else. And as ever, just to thank all our volunteers, our amazing staff, our board, who have gone above and beyond and do every day of the week in this never-ending blizzard of things to do in health and well-being at the moment. So just thank you to everybody in Healthwatch, and also the public who have been quite kind and have taken part and filled in surveys, answered questions, etc., etc. It's really, really important. Thanks. Thank you, Andrew, and I'll add my thanks to that. And now we've got two items 5 and 6, two interesting developments. Community testing project. Alice, would you mind if I pick this up? Because I think it should have been flagged under me, this one.
Yeah.
Okay. So we were asked at very, very short notice, late in August, to help out by Public Health with the community testing project for LFT testing. They were finding basically it wasn't necessarily hitting the right communities in terms of those either not testing or at high risk. And the biggest problem really was the fact that they didn't have the connections, the contacts to actually be able to do this. So felt that Healthwatch was very, very well suited to doing this. Obviously, the challenge for us in helping them out is that this is a commissioned piece of work, is that it doesn't interfere with our statutory and day-to-day work. And at very short notice, we had no real option other than our staff and volunteers and board members to help pick this up while we reorganised in order to backfill our positions. The first month in September, I think, has been hugely positive in terms of the communities we've engaged with. We've also worked in conjunction very, very well with Community United, because one of the key elements of the project was to ensure that the ethnically diverse communities and the vulnerable, who in West Berks are really hard to get to because there are relatively few of them and they don't necessarily meet in sort of standardized ways they may in bigger communities. So, you know, I want to thank all the people at Community United, and obviously that covers off Alice's other hat, for the great work that's been done, including the fantastic cricket day, where not only did we have the community testing program going on, but we also had the vaccination van, which was really successful, and the weather was superb. But yeah, that was fabulous. So the community testing project has been so successful in terms of our first month of operation that we've been asked to extend this to December and possibly even March. And we've now at least gone some of the way to ensuring we can cover off the additional workload without it interfering. So Julia Arnold is joining us from the advocacy people, and she specialises in engagement work. She's worked for Two Saints, she's worked for the council in terms of homelessness and hostels and all sorts of things, and was already occasionally doing work at the soup kitchen and things like this. So she starts full-time with us next week, and we're still looking for some more administration help for Michelle, so that again, what we don't want to do is help on one hand and then fail to be able to do our statutory duty. So I just appeal to anyone who wants to volunteer to help us with this. We are everywhere and anywhere in West Berkshire. The van is on the move 5 to 6 days a week in different places, but it does appear to be having an impact, and we managed to get the van redesigned. You can see it in the background. It was formerly badged as a highway maintenance van, which wasn't terribly helpful. So at least now it has the community testing message on. And we were joined by our MP Laura Farris on, it was either Monday or Tuesday, I'm afraid remember anymore, when we went to 8 Bells. So and she did a test in the van and was very supportive of the whole programme. So that's all I really want to say on the community testing project, and fingers crossed it continues to go well.
Thank you, Andrew. And the BHFT project, which is quite interesting.
Do you want to start that off, Andrew? Then I'll finish.
Yeah, so I was talking to BHFT for about 7 months about this, because we were interested in how you get feedback from people and getting either domiciliary help or community help in the sort of older community, because it's really difficult to get to speak to them, because often lots of them, and certainly with the pandemic, aren't able to go out and aren't really easily accessible to us. And BHFT at the same time wanted to do some work on how their rapid response service was working, and the two things sort of came together in July, August into a project. And we also invited our colleagues from Healthwatch Reading and Healthwatch Wokingham in, so it's running across all 3 areas of Berkshire West, and we're effectively interviewing people who've used both the the 2-hour service and the 2-day service, which really is there to sort of help people avoid going into hospital, and seemingly does it in a reasonably successful way. So we are we had to go through all sorts of information governance hoops and secure methods of being able to contact people and ensure that anything we were told by patients was secure. So we've done all that. We've signed an agreement with BHFT, Berkshire Healthcare Foundation Trust, and Alice has kicked off the project, and I can hand over to her as a sort of just a quick sample of how it's all going.
Well, just to share with you that between the 3 health watchers, we've got the largest caseload, to be fair. We've got about 29 people on the caseload, but trying to contact them has not been an easy thing. But we are continuing to do that, and we will still continue doing that till the deadline. And so hopefully we'll. So the thing that we are doing is speaking to them, and then recording the interview and then transcribing it. Not an easy job, but you will get there. But a lot of the raw findings at the moment is a lot of them don't remember the service, so we are having to explain to them again. And also one of the things I think my learning for that has been that it's not one call; it's a few calls before you get them to give you more information. So it's been an interesting one, to be honest, and I'm looking forward to the outcome.
Sounds as if the results might be somewhat subjective, but that's life, I guess. Why do we have the largest cohort?
Good question. I don't know, but it seems to be. I mean, it's quite interesting. Today we've got a meeting every Friday with the BHFT, Berkshire Health Foundation, Berkshire Healthcare Foundation Trust, and we don't know. And but yeah, we seem to be the largest. And in fact, Reading wanted more clients. And what's also been happening is also because of the border, a lot of the cases went to Reading, and then now they're saying, oh, that's West Berkshire, let's come back to us. So yeah, so we've ended up with largest cohort.
Okay, Leslie, you'd like to comment?
Mute.
Right, sorry. I just wanted to say that I'd be very happy to be involved, make some phone calls. If it means from the IG point of view coming in to Healthwatch, I'm quite happy to do that. So let me know what I can do and I'll make some phone calls.
I think, Leslie, you will be called next week onwards, kind of thing. So that's happening because we do have a deadline. So I it would be quite good to have, if there are other people who can help, it will be very much appreciated, because this is, I mean, a lot of people say they want to participate, then other people don't, so we've got dropouts. So I don't, I think our cohort is big enough that we will get the 20.
Okay, all right, thank you very much. And that concludes item 6. So we move on to item 7, COVID recovery survey and report. Who is kicking that off? Is that Karen, Andrew, or?
Can I kick it off? I sort of have covered a little bit of it already, and I'm really mindful of time, that we get some time to discuss the other important stuff. So we are waiting to really see where this learning comes from in terms of our system, and I'm hoping, a bit like we did with our homeless report, that potentially they use the report as a sort of starting point and either add in, subtract, or just see whether the things have been answered, because it's clear in the COVID recovery, and if we look at the huge impact on waiting times in secondary care, issues of GP access, etc., and of course the complete collapse almost of dental, NHS dental, that there are learnings that really do need to be made in case either we have yet another variant or wave of COVID, or a future different pandemic, or the the much vaunted flu pandemic actually turns up. We really should be able to learn from what we've all been through and what services have been through, to hopefully mitigate things so that we don't end up with the unexpected consequences that we're currently dealing with of a completely worn out health and social care service, a lack of new people coming through or trained people to help pick up the weight, and a population that can't necessarily access the services they need. So I think it could be a really important piece of work. Interestingly, we did finally get a response from the Minister of State for Care, Helen Whately, which will be slotted into the report. It only took them 4 months, and of course, sadly for her, she's now no longer Minister of Care, so perhaps karma may have had something to do with that, who knows, but that will go in the report, and we'll recirculate the latest version. Thanks, that's all I want to say. Karen, I don't know if there's anything you want to pick up.
No.
Thanks. Okay, thank you very much. Move on to item 8, most of which I think we've probably covered actually before, but contact and issues report, thinking together 5. Andrew or Adrian?
I think we've kind of covered this off, so I think what I want to do with Adrian and Michelle is effectively work out the best time to launch it, and whether it's, funnily enough, World Mental Health Day is coming up, isn't it, Adrian?
Yeah.
And who knows, that might be the perfect day.
Yeah, 10th of October.
I can see no better day to launch it, so perhaps we should agree that's what we will do. VOD we've already covered off.
Sorry, Andrew, just coming back to the time. It'll go to the Health and Wellbeing Board, will it?
I'm not really clear, Adrian. I think Matt will report on it via Mahag.
Right.
And I think the next obvious step is that we are then due to hold another Thinking Together event, which we've talked about doing with young people, which I think is really, really key, based on all the pressures of mental health services. And
the thing is, there's a tie-in with the delivery plan for the mental health part of the Joint Health and Wellbeing Strategy. There's an overlap between some of the things in that delivery plan and what's in our report. So it might be a way of, helping push things forward.
Yeah.
And that's going to be, it was reported to this last Health and Wellbeing Board, as you know, but I think they're going to sort of sign it off at the next one.
Yeah, well, I think that's really sensible, because it's a key tenet of the Joint Health and Wellbeing Strategy, which, funnily enough, is also in this section. So I think as many things as we can do to join things up and follow through, we should, but happy to take any help and advice on that going forward. Leslie, can I ask you to come in and briefly talk about the CAMS report and where we are, because I think we're virtually done, aren't we, and finished, and it's been to the CCG.
Yes. Do you want me to mention comments?
Please do.
We've had, yeah, we did get some interesting comments from Andy Fitton, who's the lead for the commissioning lead for CAMS, and it was quite interesting because he was asking, for example, for us to be more specific, possibly about ADHD and autistic spectrum disorder, whether we could include something about that, because they've specifically been doing more work in that area. And the fact of the matter is we can't really do that because we didn't ask those questions on the survey. So it's the survey was non-specific in terms of what your child has been diagnosed with or what kind of help you're seeking. We didn't include those questions, and therefore we cannot put anything in. It would be speculation on our part, even if I trawled through the comments and tried to find, oh, this person had mentioned ADHD or this person had mentioned autism. That isn't possible in this kind of survey. So that one couldn't be done. And then also he wanted to point out how busy the service is and how many referrals they get in terms of across Berkshire West. So the number he quoted was something like 1,600 referrals in 2021 for CAMS. But again, we would have had to be, for me to include that, I think he wanted to show, well, it's a very, very busy service, and therefore the number of comments on your survey wouldn't perhaps be representative, because there were, just over 100. So that was the whole of Berkshire West, and our survey was only for West Berkshire. So we would have needed to have gone back and definitely found there was only people from West Berkshire, and then found the number of referrals just in West Berkshire, not for the whole of Berkshire West. Otherwise it makes it look as if it isn't a representative sample. But if you said, and this is just my basic thinking really, if you said that a third of the people roughly would have, a third of the referrals would have been from West Berkshire. I mean, okay, it's not exact, but that would have been around 500, 550 or something. And then our number of comments, our respondents of over 100 looks very strong, in fact. So I talked to Andrew about this, and we sort of decided that it really wasn't worth trying to put that in, those figures that he had suggested. It wouldn't really make any difference actually to what we found in the report. It wouldn't strengthen or otherwise or take away from the survey itself. So I think that it's really ready to go. And given that, as you all know, there's been CAMS has been in the news nationally for these terrible waiting times. So it's not just us that's in this position, it's across the whole country. And this is just our survey, I feel, is just another piece of evidence that is an important part of the jigsaw, that people themselves who are trying to access this service are just not getting the service that they need. And even when they do get referrals, they're not really happy with what they're getting in terms of treatment and help. So I feel quite clear that we should go ahead and publish the report. I think we've shown it to we've shown it to the commissioners, and I think in terms of, I mean, have you actually responded, Andrew, to Andy Fitton's email?
I haven't had a chance to as yet, because I hoped I'd bump into him at the mental health board and he wasn't there. So
Oh, right. Okay.
I that's the last thing I need to do, is just sort of respond to him saying thanks very much. But you know, we're confident having the sample size based on purely West Berks, which it was.
Yeah.
We think the report's good enough to go.
Yeah.
And I think the other thing I just quickly wanted to pick up is that, you know, part of their overall mental health strategy, which they're very pleased with, and it's good to see some funding genuinely coming in.
Absolutely.
But then one of the key tenets of the very high level services in Tier 4 for children and young people is Hunter Combe House, which is in special measures. And you know, BBC Berkshire did a really good piece on it, and they had me on to briefly talk about it. But when you listen to the testimony of people who've been there, and the parents of the people who've been there, you know, I think, as I said, how in 2021 are we delivering that level of service? You know, Hunter Combe may not be as bad, but it might be the Winterbourne View moment for our system.
Yeah.
And it just has to decide, how is it going to cope with the demand, the change in services, and is it good enough to say, well, in 3 years' time it will be better? You know, the parity of esteem was talked about, I can't even remember how long ago, and it doesn't seem to be that much closer.
No.
And what concerns me as well, which we'll come on to with the ICS, is there seems to be this sort of somewhat black hole of communications and accountability of, well, who is accountable? It was really interesting. The BBC couldn't get hold of anyone from NHS England, from the CCG, from the ICS to come and talk about, you know, a really vital part of their system in special measures for the third time. And doesn't that say an awful lot, that they were relying only on a response from the commissioned provider, who's I think the Priory Group, but the actual people who were responsible for it weren't prepared to even engage. And I don't think that's acceptable for NHS England. I think they need to do better.
And how are we? I mean, it's Claire Murdoch, it's Tim Kendall. I mean, there's not. There's a vacancy at the moment in terms of the commissioner within NHS England, but Tim Kendall is the clinical director for mental health, and then you've got Claire Murdoch, who's the she's based out of.
Sorry, we just lost you there, Amanda.
Well, no, I'm just trying to sort of, you know, I just think it's.
Your audio comes and goes.
Can you hear me?
Can now, but your audio is coming and going, sadly.
Yeah. I was just saying, you know, Tim Kendall is the mental health clinical director, and he has a team beneath him. Lord Pryor is the chair of NHS England and is particularly interested in mental health. And then you've got Claire Murdoch, who is the DH kind of czar for mental health, and she's a nurse operating out of, but obviously very senior, leading mental health. So, you know, there's a vacancy in NHS England on the commissioning side at the moment at the top, and it is quite difficult. But I'm just thinking, should we try harder to make sure something is landing at that level when we're concerned that while there is, you know, we're really pleased that there's more funding coming in and all of this kind of stuff, and we know that the service is working incredibly hard to try and make things happen, but it needs to be it needs to be elevated and escalated, especially if we do think that we've got something, not to the extent of Winterbourne, but if we do think we've got something in our patch that could be exemplifying this, I just wonder what, you know, and should we be talking to Laura Farris and saying that why are we not getting the engagement in there? Yeah,
I mean, I mentioned this equally in health and well-being in terms of the sort of whole GP access issues, and you know, isn't it really telling that in the number of years I've been doing this, the comms team involved in Berkshire West and our system is at its smallest point ever, when comms is so very vital. And I think that in itself tells you an awful lot in terms of how important the health system considers communicating with the public. And I think they need to do better. They need to look at other industries that do this better. You know, it's not about hiding from responsibility or just pretending everything's fine. You know, the public needs honesty and transparency, and if things are tough, tell them.
And this is absolutely the role of Healthwatch to do that and to hold the mirror up. So I think this is really quite important. I'm sorry, I know I've not been in touch as much over the summer, but yeah, I'll maybe pick up with you separately, Leslie, maybe.
I think that would be really helpful, because I think if we are going to launch the CAMS report, a bit like we did with the COVID report, where we wrote to all the ministers of state, admittedly some of them responded, some of them didn't, but I think if we could tie in perhaps a carefully crafted introduction and we could send it to all the people you've talked about, Amanda, who knows, and maybe we invite them to the scrutiny board or health and well-being, or just a public chat about mental health. Maybe they can come to Thinking Together 6.
Yeah, and I just think that if we can get that, you know, it's not about what gets measured gets done, but even just what gets kind of related and looked at will have
gets noticed and talked about.
Yeah, and I'll talk to Laura's office as well. So if you can have a quick chat with Leslie or an email chat about that, and then we'll come up with something in the next week or two. We still want to do the focus group as well once we've got it going, because I think it's important that we keep talking to the parents and the children here, and perhaps Thinking Together 6 with a younger person's look might help encapsulate its launch and what have you. So Adrian, I don't know if you can have a think about how best we might bring all of this together, and equally with the strategy, because that's the next thing sort of we've talked about. This should tie together, it feels.
Okay, thank you. And we'll move on now to item 9, which some of which we have talked about, but that's over to Michelle and Alice. I don't know who's going first. Bob, Bob HW waiting time surveys. Who's doing that?
Do you want me to do that, Michelle?
Yeah, I'm not quite sure why my name's next to it. I think it's because it should be next to the CAMS focus group one.
Okay.
Looks like it's just slipped from the agenda.
Okay. So basically, Healthwatch England have done a national survey on waiting times and its effects, and it's been agreed at the Bob level that all the health watchers in the Bob patch will do their version of it. So what we've done is we've populated a waiting time survey with all of our relevant hospitals, and we are about to launch that next week. So the survey is sort of pre-populated, and all we will have to do is get it launched, get it on social media, and just try and get as many people from Berkshire West and West Berkshire to fill it in, to give us some ammunition, because the ICS, the Integrated Care System, are looking at this sort of thing, and we have the ability to go and present it to them as a system-wide, with some proper granular data. So people will be talking about Royal Berks, will be talking about John Radcliffe, will be talking about Aylesbury or wherever it happens to be. So it should be very useful to them. And of course it also backs up Healthwatch England national one, which will no doubt be presented to DH and NHS England. So that's pretty much ready to go. Once I've got the final version, I'll whiz it round to all the board members so as you can have a look and comment. So we have based it pretty much on something that Healthwatch England has written, and then we've just tweaked it a bit. So we're going to have to pretty much go with what it is, and then it'll be really interesting to see what we get back. So that's the waiting times survey.
Thank you. CAMS focus group, Michelle?
Yeah, I think the CAMS focus group and the carer survey were pretty much covered off when we talked about the action log earlier on.
Fine. Alice, I guess, Carers Week survey?
I think it's the same one that Michelle was talking about. You know, the uptake has not been fantastic, so we need to work a little bit more with that. Yeah, and I think, you know, we've been trying to do it on Carers Weeks kind of thing. Maybe we should not be doing that, but be an ongoing project.
Okay, well, I hope that does improve a little. And I guess if you diversity forum.
Well, the interesting thing is now we are part of the community testing thing, so we're going to be presenting the importance of community testing to the diversity forum. So a date is going to be set so that the communities can hear why we are doing the testing, why it's important to record, and also where to get the kit. So that's in the pipeline.
I must confess, I, to a degree, felt that it was a bit like handing Smarties out. Is there any system for it's not Oxford Health who's doing the current one? They're based in Berkshire, in Buckinghamshire, aren't they?
Solution for Health.
Solution for Health. I'm just interested in knowing if there is any means of recording whether they actually get information back from the people they hand the test kits out, or they merely go in the bin or something.
Can I take that, Andrew, quickly? Yep. Mike, I think where you've helped us out has been places like Calcott, Sainsbury's, where it hasn't been a massive uptake. The places they're hitting now that Alice has been setting up with the communities, they actually are engaging with the communities, aren't they, Alice? And they are getting people to test. Alice has done a great job with that, making sure that the community have felt comfortable. And then Solutions for Health have gone in and given a presentation, and in some instances they've given a presentation. So the uptake is much better than it was, I think, Mike, when you originally were helping out. It's more specific now. The locations that we're hitting certain target groups and certain areas. Alice, anything you want to comment on that? I think
I have.
Yep, go.
Andrew?
Really key. All of the tests are barcode tracked. So although we don't necessarily get the information back, they are able to say that they took a set with a set of barcodes. So when people record their tests, it's matched against where it was given out, which is really helpful. So if we do a particular community and you know that they were the ones that got the box with that barcode on, it helps give them some tracking of how many were filled in, you know, and that goes back to public health. So there is some tracking on the stuff at Sainsbury's, Mike, where things were just being handed out. There's pretty much, it's fairly meaningless, but the change in emphasis has made this much better.
Oh, good, interesting. And I suppose, of course, doing it at somewhere like Tesco's and Sainsbury's, you've got a massive number of people. I assume that there are not as many people in some other venues like 8 Bells and so on that they have been doing, which does mean that they can organise testing far better.
Sure.
Fine. The maternity forum, is that Leslie? Is that Alice?
I haven't really had much to do with it, but what?
But I think we need to go back to it, because now with all the stuff that's happening nationally about maternity services, so this is something we have to. I'm planning to catch up with. So it's on the pipeline.
Okay, thank you very much. And how about an update on our volunteers? That seems to be fairly decreasing, the number of volunteers.
Yeah, I mean, I think in a lot of the decreasing is because we are not doing face to face, and I think you'll get back much better. And people. I mean, Jane is here. Jane's been very helpful in doing a lot of our engagement as well. So thank you very much, Jane. So, and I think more people see us doing stuff, they might be, people will start engaging. So we are still recruiting people. Hopefully we'll get the numbers up soon.
And our social media presence?
I think that personally, I think that's more improved because we seem to be having a lot more engagement that way. We've had a few feedbacks as well from the social media engagement.
Have we had any continued anti-vaccination protest?
Not as yet, no. There is a fascinating debate going on our Twitter feed about third vaccination doses and transplant patients that we've had very little to do with. They've just decided to have a conversation on our Twitter feed, which has been incredibly helpful, funnily enough, because it is the patients discussing things amongst themselves, but it gives us very rich food for thought, and we were actually able to take it back to the vaccination committee, who weren't entirely clear themselves. So there's been some further NHS communication out, and we had potentially talked about doing it quickly as an AOB, but a lady called Jackie Evans, who was going to come and ask about it in AOB, has sort of had her questions answered, but perhaps we will cover it very briefly in AOB, Mike.
Okay, right, thank you very much.
Mike, can I just have one more thing added to this quality and performance one is our Great Western
yes.
project, kind of enter in view. Well, at the moment it's being written up, so by the end of this month it will be ready to present to you guys with recommendations, and hope before it's being presented to the executive group at Great Western Hospital.
And who is writing this up?
Berkshire and Swindon.
Yeah.
But we are also participating in it. So we've been having meetings to make sure that everything is in place. But it's been quite an interesting information that's coming out. One of the things being in emergency departments, whereby people are being sent to the department by NHS 111 and those kind of stuff. So there are things that are really rich data coming out.
Excellent. Actually, these things seem quite successful where we are working with other health watches. Good to see.
They do.
Yeah. Right, well, thank you for that. We'll move on to item 11, which is an update on the SDP ICS. Andrew, do you want to?
Yeah, I think this is where I try and pretend I'm Brian Cox and I can talk about black holes on the edge of the universe that no one can see. It really feels very much like this. There's almost radio silence because there was a national decision to get all of the chairs and chief officers to reapply or to advertise out for their jobs. So that is currently ongoing, and it's just created utter there's just no sense of travel until that process finishes in November. So we've had a real torrid time really finding out what's going on, and it's a real concern because there's a real accountability gap, because the transformation program is carrying on. And one of the key things that NHS England has asked the ICS to do is come up with an engagement strategy by April 2022. And, as it currently stands, they're not engaging with anyone in terms of members of the public. They don't know how they're going to do it. And the time period is shortening. And these are really significant changes that are being mooted. So, on a positive note, Catherine Williams, our joint officer, has continued to liaise with the officers who are still in place. She's managed to present some papers on our joint work and on what's going on, and it seems to have been very well received. The downside was that we were one of the first ICS that had managed to agree a collaborative Healthwatch approach, which is what the new ICS model is asking for. But the funding for our post finishes in December, and the ICS will have barely been operational functionally for a month. So what we're hoping is that they will roll the post over for a continued period when it really does actually start to get into its own. So we were ahead of the game in terms of having a single representative for the ICS. there are although the bill is going through Parliament, all the guidance is very vague. So it said Healthwatch must be involved in some of the place-based activity, but there's a real feeling that it's actually at the integrated board itself that decisions are going to be made, because that's where the money's coming from. And Healthwatch England's advice is effectively do some horse trading now. But it's a real letdown that, considering Healthwatch England have helped so much with NHS and DHSC, that they've left it frankly so random. They're saying that, you know, patient engagement, public engagement is key to everything. And then they haven't really outlined how. So it's pretty much a free-for-all in terms of getting in there. The only bit that I think is really defined is the voluntary sector element in terms of their representation, where effectively the voluntary sector has to kind of all agree who's going to do it. But the confusion has also been that they want people who are actually providing services to be part of that piece of the jigsaw. So you have people with a vested interest because they would like the service for X, Y, or Z, and they're rather mistakenly saying, well, there's patient and public engagement. Well, not really. Not if you're, you know, the commissioner of a service to someone. You can't really expect them to honestly and openly tell you you're doing something badly. So it's all a little confusing. I'm hoping we get some further clarity. Our Healthwatch is working quite well together on it, but equally we still lack a senior officer in Berkshire West, and this is now having significant issues because we just don't have anyone to take things to with the radio science ICS. So yeah, it's quite worrying, I think. Amanda, I noticed you've got a question.
Yeah, I mean, I think everybody's feeling it. It's not just Healthwatch. It's like everybody is feeling it. There was guidance published yesterday around funding flows, and it was drafted and consulted upon in April. And you know, the accountancy section of NHS England is they're kind of coming out of COVID, so everything's still under COVID legislation. They're going to try and get things right for April 2022, but they're working in a very confused way at the moment, with like even just issuing guidance for the last 6 months of 21/22. And one of the things I was thinking about the other day was for Healthwatch generally, and for Healthwatch West Berkshire, I think it's very similar to how I'm thinking about it from my job's perspective, is that there are some things that we need to deal with at an ICS level, and there are some things that are going to be funded and decisions made at a provider network level, and then there's some things that are going to be at the GP network level. And actually what we should probably do is really rough and ready. I don't think we should do it root and branch, but for the issues that we're particularly engaged in, we should maybe have a conversation about which level is the strategy and the decision being taken, and make sure that we kind of engage at the place level. You know, it's no point in engaging at the GP network level on something that actually is absolutely an ICS broad thing. But I think the provider networks for acute and trust level stuff is a real power base, and I think if we've got things that we need to engage on there, we should be kind of finding out, okay, well, who are the people that we should be talking to on that front. So, you know, say there's 6 things that we're prioritising. Let's just say, okay, is it ICS at the whole? Is it provider network, or is it GP network? And then you can basically try and engage with the people that are at least thinking about it. Whereas, you know, they won't be at ICS level on everything. And at least that makes our engagement more targeted as well. It's just an idea.
I think it's a really, really good suggestion. And Adrian, previous to our other conversation, I do wonder if we should be aligning ourselves with things like the PPG to potentially help a similar sort of process happen for PPGs. We should certainly do the same with the voluntary sector, and we do have to have a voluntary sector conversation in our area, because I see no means currently how our existing voluntary sector in West Berkshire are even going to be able to get to the bottom of this, because it is such a web of structures and different people and different commissioning. So I think we should be there as a sort of a little bit of an information post for people. But I just get the impression from the senior management at the ICS that the more that we do sometimes have to go in, not just representing ourselves or backed up with other organisations, and that could be the PPGs. I think on our own and on the PPGs on their own, would probably have a weaker case. So I think we probably need to think about doing some work with that.
Right, thank you, Andrew. I just wanted to say that I, along with other chairs, had a meeting with the current chair, who obviously had to apply along with 5 others for his post. So we're still waiting to know whether he still has a post or whether there will be somebody new in that role. But I understand the CCGs disappear in April next year, and that their current priorities are business as usual and actually the transformation to the ICS. The chair was very positive towards working with Healthwatch. He thinks that perhaps there needs to be a reset of our sort of current relationships. But he was very pro, but I don't know at the end of the day who it will end up with actually extending the contract of our joint officer. And of course, if they don't know anything if it doesn't really come to fruition until November, the contract expiring in December is very difficult if it's new people to have any real relevant view on. But anyway, I'm sure it will actually continue one way or another. And in fact, I don't know how many people have actually applied for the chief executive job. Do you know, Andrew?
I'm afraid we haven't had any oversight of this at all. So, but I'd be very surprised if Mr. Kent doesn't reappear. Yeah,
I'm sure you're right. Which we shall have to see about that, because he's very much a metrics man, which may have led perhaps to not quite as heavy an involvement on other sides. I understand that as soon as the CEO and chairs are in place, there will be a proper communication strategy in place. So we're talking about probably December 31st at latest, hopefully. Okay.
Just materially for the person that's doing the role at the moment, if a decision on the future funding of the role is not going to be made till November and their contract finishes in December, are we at risk of them not continuing anyway because they just need to sort out that, or are they able to cope with the ambiguity of the situation?
I think they're aware of the ambiguity, but yes, it's far from ideal, but we are doing some work to see whether or not we can get some clarity. And actually, I'd be really surprised if they don't do this, because it's a relatively straightforward thing to do. It proves that they are actually doing something. So if they don't carry it on, they've then got to come back with a different idea of, well, how are you going to do this? So I'd be really disappointed if they didn't at least make the offer to continue the post. But yes, you're absolutely right. We need to do it sooner rather than later, because it's not fair on Catherine.
And maybe a proposal could be, if they can't make the decision for the full year, at least extend it till end of March, because I'm sure they've got budget this year.
Yeah. I think so. I think
that happens. I just think that it would be such a shame if they couldn't reach an agreement in November and then you kind of lose somebody who's in post.
Oh yeah, absolutely. I mean, I think it will go forward.
Oh, good. That's fine. I was just obviously not close to it.
Yeah, don't worry. Fine. Okay, so I think that ends item 11. Item 12, the work plan for 21-22. Andrew?
Yeah, so we've done some amendments on this, but we kind of agreed this way back when, and then there was some issues that someone wanted to rediscuss, and sadly they're no longer part of the board. So effectively what I almost want to do is say, can the board just frankly go back to what it had already ratified, because this is a moving document and it's been drafted far too long, and I want to get it on the website and actually start then amending it and moving things up and down. And what we've done is we've added the commission services on there that we talked about. We've updated some of the details of what's been going on, and what I've tasked the team to do once we get to next week is to actually go through it again on a line by line basis and produce a version 2 dated October the 5th, because what we want to be able to do is see this document moving, and as things like waiting times come in or go out, we add to them, or other issues, so whether it's hunter comb or cams or blood bottles or blood tests or diagnostics, whatever, we can't really do it until we've got a starting document. So if the board are happy to accept that this is our current work plan, I would be very, very grateful, and then we can immediately start amending it on Monday.
Do we have any anti that plan? Adrian?
Well, just one general point and one specific point, which is not particularly in relation to what you've just asked, Andrew, but I mean, the general point is I think it looks quite ambitious. There's an awful lot on there, and, you know, just a bit of a worry of taking on too much, and sort of concern about the impact on our staff. The other very detailed point was the work on end of life. I'd be quite keen to be, I know that's sort of on pause at the moment, but when there are discussions about that again, I'd be interested to be involved, because I'm doing some stuff on that at the Royal Bark, so that would be helpful for me in that role, but I can maybe also able to feed some things through to what they do.
Yeah, I think you know, with an awful lot of this, because I noticed on we on our existing agenda we talked about CHC, which has kind of fallen down our immediacy register, but still remains a real thorn, and I think at some point will be picked up by the ICS, because the ICS has such wide disparity. But our Healthwatch partners have also agreed that they are keeping a watching brief on it, but aren't necessarily going to do anything with it. So I absolutely take your point, Adrian, and I agree with your point. But the problem is our brief is to effectively look at all of health and social care with a quarter of the tools that we need to do it with. So you know, we've become the greatest plate spinning organisation I know, and the trick is to make sure none of them drop.
Well, I do think it's important to get this on the website, warts and all. We can't waste forever trying to make it perfect.
Yeah, I think perfect is
Sooner
not acceptable.
It's on, the better.
So could we take that board as an action, and then, as I said, as of next week we start amending it, and as amends go through we approve the amends at the next board meeting, and because equally we will be reporting back on both the work plan and we will be reporting back on other activity that's come across our patch, because as I said, things change so often at the moment. It's really quite difficult to keep a track and on everything, but that would be really helpful for us.
So do we have any dissenters to that? And I think you can take that as support, Andrew, to go ahead.
Thank you, board.
Right, well, we now move on to questions from the public and the audience. I take we have no questions in writing, Andrew.
We haven't received any, I don't think, have we, Michelle?
So unless I'm totally
no
wrong,
questions.
Looking at the list, we have Jane as the only one I think with us able to ask a question. Do you have anything you want to ask, Jane? No? Fine. So I think that covers that item. Right. Any other business? Where should we start, Adrian?
Well, I was just going to mention the health and wellbeing strategy I've brought before the board a few times. And just to note that the draft delivery plans went to the Health and Wellbeing Board on Thursday. Although, as you know, I've sort of had some problems with the general approach. I think the priorities are good ones, and the delivery plans actually make a lot of sense. But they have taken some notice of the consultation over the summer. They've increased what they would hope to do on social determinants. I'm not sure it's quite clear yet how they're going to do it, but it may be an opportunity for us to influence things through those delivery plans. I think they're intending to implement them mainly through existing boards, and I think we have representation on a number of those boards, like the Mental Health Action Group, the Engagement Group, Children's Delivery Group. I think, are we on?
We've sort of got a loose invite, but actually we lack the staff or currently anyone who's volunteered to go.
But in principle, there may be a mechanism there for us influencing what happens. Getting in at the point when decisions are being made might be a good point to influence.
And Michelle, can you capture that? Thanks.
Karen? Sorry, Leslie first. I apologise. Leslie first.
Oh, it was just a quickie, really. Just thinking about, you may not know, but Public Health England obviously have changed, and the health protection side of it has become the UK Health and Security Agency, and the health improvement side has become the Office for Health Improvement and Disparities.
Oh.
So disparities is our new word for health inequalities. Not quite sure why they felt they needed to change it, but there you are.
Oh.
So it puts prevention at the heart to help people live longer, healthier and happier lives and tackle inequalities and level up the UK.
Very good.
There you are. Just so you know.
Karen?
Yeah, I've just turned. I'm not I'm not on very well, so I've just taken my my camera off. I'd be interested to know. You mentioned earlier about some things that were happening that came up at the Health and Wellbeing Board. Can you expand on that and tell us a bit more?
What in particular, Karen? Sorry.
Well, about local GP surgeries and things, and the state of the nation.
Adrian, do you want to take that?
Yeah, there was a presentation from the head of the LMC, the Local Medical Committee, which is a sort of grouping for GPs, and he sort of gave a fairly impassioned plea about how GPs have been unfairly maligned in some of the media, and it was quite quite a convincing case that backed up by statistics that demand has gone up, workforce has gone down. That was the case before the pandemic. I mean, there are still issues about infection control and not being able to have too many people in the surgery waiting rooms. But the move to online access was happening anyway. And in fact, given the increase in demand, reduced workload, the only way to deal with it is through triaging. And in fact, it is working reasonably well in most cases. More than half of people are still being seen face to face. So, the Daily Mail campaign of, you must be able to be seen face to face again, as if it isn't happening, I think is just misrepresentation. And the conclusion, I think, of everybody around the table was we need to get this message out to the patients. A lot of people don't understand. At our PPG meeting last week, the GP mentioned that she had somebody sitting in front of her who said, "When are you going to start face-to-face consultations again?" Totally missed the irony of it. So I think there's a job to be done about getting some of that message across. So I thought it was quite a useful session.
So if this was going to be an article or something we might do for the Newbury Weekly, who would be the person who'd write it?
I would get him to do
it. Who is he?
He's Dr. Richard Wood. And if you, or we can get you to him via Gordon Oliver at the site, because effectively he spoke very passionately, but also he backed, as Adrian said, everything up. And also what he delivered is what the newspapers aren't telling people, which is that this hybrid model is here to stay. So the days of the Citadel and, the doctor at your bedside mopping your brow are gone, because we have a deficit of staff, we have an increased demand, we have new ways of doing things, we have a large portion of the population who quite like the way things are done via telephone, digital, or what have you, and we can't provide a GP on every street corner. So it's rather disingenuous for the newspapers to be banging on about, return to sort of 1960s doctoring from Call the Midwife, which is just, it's an impossible nirvana that doesn't exist, unless, of course, they want to increase their taxes by 10% to pay for it. But we just haven't got the workforce either, which seems to be a fairly universal issue at the moment. So effectively, his plea was to, I suppose, for the public to sort of realise that the world has changed somewhat, and to help the profession get it right. There was no admission that everything was perfect, but they did call it a hybrid model. They didn't, there's some really key things, like the average telephone consultation takes 8 minutes, the average face-to-face takes 14. You do not need to be a professor of mathematics to do that and work out how you get through that. The fact that, I think he said, was it 89% of prognosis work is done from the client history rather than the person sat in front of them, and these are really useful things that if they could get out to the public would have a better understanding of why actually seeing whether or not you're slightly out of breath or looking a bit pasty probably isn't going to yield a great deal, but your previous history or medication or whatever will, in combination with a phone call saying, so how are you finding walking up the hill, the stairs? And you don't need to be in front of someone to do that. So I think that equally he did take upon, as did the representative of the CCG, that having the smallest comms team they've ever had is not helpful when you're in a communications battle with media giants who have a different agenda. And so, not everything is solved by clinicians or pills, and there isn't a shortage of Marcom's professionals out there, and they need some quickly. And I would encourage everyone talking to their GP practices to, ensure that comms improves. There's so many more ways of getting it out there, and we need to re-educate people as well. It's really not helpful when whatever Public Health are now called and NHS England keep coming up with national campaigns going, visit your GP. It's hardly surprising that the public then go, well, I can't see my GP. Yes, but you can see the nurse practitioner, the physician's associate, the clinical pharmacist. So the comms of NHS England has to change as well. But yeah, fascinating stuff. And it is on the recording of the Health and Wellbeing Board, which is available to anyone who wants to watch it.
Okay.
Karen, if you are doing something for the Newbury Weekly News, I'm happy to work with you, and we could pull together some basic information we could send around to the PPG so they can use it in their own newsletters.
That would be really good. I'm just putting an email out to Gordon to try and get in contact with this GP, this Richard Wood. because it would be useful to get something like that. So, but perhaps we'll need to edit it and things. Adrian.
Yeah.
Yeah. The other thing on a similar score, Karen.
Yeah.
While you're talking about the press, we appear to have been given a page on mental health in Out and About in every edition. It started off as a one-off, and now they keep harassing me, every other month, saying,
Right.
"Would you like, well, not harassing me, that's the wrong word, but they're saying, we have a page available for you." Now, Adrian, we did do 2 versions last time, so I don't know whether you feel the other one could almost seamlessly slot in. But, it's worth bearing in mind that, if we have got that as a resource, then straight away, both the Health and Wellbeing Board and ourselves, we have a lovely piece on mental health that we can keep pushing out every 2 or 3 months. And at the moment, it's been a little bit too ad hoc for me. So we probably need to feed back to Mental Health Action Group, say, look, we have something here that's available for you every quarter. So you have got a program, and equally talking to Andy Fitton and people like this, we offer them the ability to work with us on it.
Very good. Leslie, is your hand still up? No. Amanda, do you have any item? Anyone else? Andrew, your hand is up.
Yeah, I just quickly thought we'd catch up on vaccinations, just very, very briefly. As I said, this came from a Twitter conversation going on using our Twitter feed without us involved, and it was quite fascinating. So there's a little bit of difficulty with people understanding the difference between a third COVID vaccination and the booster vaccination, and feel free for anyone who's better qualified to correct me if I get this wrong. The third jab is a proper full dose COVID jab, as in the ones you will have had 1 and 2, and is aimed at people with severe immunosuppressed conditions. So they may be going through chemo, they may be transplant patients, etc., etc. And the booster is pretty much the rest of the population where vaccine efficacy may be waning. There's either 180 or 182 days wait. There seems again to be some issues with which number is it. So you need basically to have a 6-month gap between your second vaccination and your booster or your third jab. People will, I'm told, be contacted, but certainly I think the only grey area for me that was slightly concerning was with the transplant patients and people who feel they are at higher risk, that the NHS has got to this a bit late, so they're asking consultants to ensure that people are included. But it appears to be there is a bit of a data gap here in terms of actually identifying who these people are. And also your level of immunosuppressants depends on when your treatment was as well. And I did hear what I thought was a really wise piece of information, which is if you're offered something, take it. Don't worry too much whether it's the third or the booster, because depending on who you are, you will end up with the right amount of both if you should be getting it. But it's basically, if you're offered, take it. Worry about which one it is later, or follow it up with your GP. But I think again, it's comms. It's comms.
And the only thing I'd add to what you're saying is that there's also for the 12 to 15-year-olds as well. I think it's important to know that the people who are children that are 12 to 15 that are living with a vulnerable adult can get, I think, the two-dose vaccination, whereas the 12 to 15-year-olds that are in schools, I think, are just getting 1. So that's another sort of nuance, and it is difficult to get the communication out. But I think, especially because of the press about the 12 to 15-year-olds as well, and whether or not it was, the very nuanced decision that the JCVI and the government had to make about whether to go ahead or not. I think that's probably made it difficult for people who are vulnerable and have children because it puts them in a difficult situation as well and not understanding it. But I don't know whether I would be able to correct you or not on the third dose versus the booster. It's not something I've come across so much. Yeah.
I think the booster is meant to be half strength, isn't it?
Something like that, yeah.
The Moderna one is, but the other one isn't. Yeah, they've worked out that the Moderna vaccine can be half strength, whereas the Pfizer one, I think, is.
And the booster's largely only going to be Pfizer or Moderna, isn't it, Amanda?
Yeah.
Yeah.
So
yeah.
the AZ won't be given as a...
It's because of the age group of the people requiring a booster that they're basically the ones that... Oh, no, actually, it's not.
No, it's not. It's the other way around. But I hadn't heard whether people would...
The AZ one, I think, is going mainly to COVAX, which is the... Yeah,
I think we washed our hands of it.
We've had a difficult situation in the family. My grandchildren had COVID.
no.
They're in the 12 to 16 group, and were quite poorly. And then 3 weeks later, they had their jab, and apparently they didn't know, they weren't told that they should not have had the jab until 6 weeks after having, which is actually could be very serious, and they have been very poorly.
Things.
So I've put them in touch with their Healthwatch in where they live, but I mean that could be serious.
Well, I think the main point about delay is not actually a problem with health. It's if something goes wrong, you are unable to determine whether it's the original illness or the actual vaccine.
I see.
Whereas I think if you look in the what is it, the black book, whatever, it actually states something like 14 days. Doesn't state what people, I mean, they come up with these ad hoc figures as we found out or protocols as we found when we've been supporting the vaccination van, that there's not always a great deal of science behind what they say.
Yeah, we were just told that if someone, we had to ask them if they'd had COVID, and if they had, we needed to know when, and if it was a certain amount of time, then we had to turn them away. Wasn't it, Alice? We weren't allowed to, we had a couple
I thought it was 28 days on the van. I seem to recall.
I think that's what they were saying, 28 days. But that's it's not what it says in the...
And just going back to your point, Amanda, a friend of mine's daughter, she's vulnerable. So her daughter, who is 13, had the vaccination. But as far as I'm aware, she's only had one, and they haven't told her she needs to have a second one.
Yeah, I mean, I'll double check because my sister's vulnerable as well, and her son has had it, and I think is having two. I mean, I'm not coming from my kind of background. It's more personal, but yeah, that was my understanding, was that they were meant to have two. So it is confusing, isn't it? And I think the advice is take what you're given, unless you've had COVID in the last 4 weeks, is probably a good one, isn't it?
So who knows about this? If we were going to write an article about this to tell the public, who knows? Who's the fount of all knowledge?
I would have thought the public health director from the CCG would be able to give you that. I mean, there's a lot of information online as well about COVID vaccines. Yeah.
But what do you believe?
Well, it's not so much what you believe; it's the fact that it isn't necessarily in a coherent form. And one of the challenges is it isn't straightforward. It isn't this or that, because you've got to take into account, as Amanda said, if you have a vulnerable person in the house, if you're a child with vulnerabilities from certain key things. So the public wants 3-word statements all the time, and I'm afraid this, COVID isn't quite as accommodating to be able to do that. So, as I said, I think better comms all the time would be much better, because it is confusing.
I don't mean general online. I mean just pulling together the various bits of the protocols and government advice on this is when, because also the time period for when a different locality is going to be able to implement these things is slightly different as well. So, but when it comes, this is the
and also that they haven't been very clear with where flu fits in as well. Yeah. And the challenges with flu have been about supply rather than anything else. So we have ended up with this sort of perfect storm of whether or not you can give flu together with COVID or not. I'm still not 100% clear myself.
They're doing it in school that way.
Yeah, and also in terms of, well, the flu vaccine's been delayed because of supply, so they were cancelling flu clinics. They've cancelled, I'm led to believe, the COVID jabs for the vulnerable on a PCN level in West Berks. So yeah, so it is a bit of a mess.
But surely there is someone within this piece in public health that is coordinating the local plan. So
in theory, but I think that's complicated by the fact that the people delivering it are based in the CCG, and again, in theory, Oxford were doing it for everyone, but Oxford have stopped doing the mobile thing.
Okay.
Or it's suspended for a month.
So, sorry, I mean, there are obviously lots of people who ought to have received their booster by now. They were starting doing it in December, weren't they, originally, or early January? Is that happening? Or?
I think the boosters are, but actually, if you think about it, Mike, the people who are going to be getting it first are going to be health and care staff, followed by the kind of over 80s. So I think they'll get to them quite quickly. It'll be the other cohorts that are going to be slightly more delayed, but obviously getting it into the health and care staff and care home staff and people like that is absolutely vital coming into a winter. The other thing that I did briefly want to touch on as well is the appeal from Royal Berks about the number of young children with this respiratory condition, RSV, that I'd never heard of, which normally comes up in the winter and has been rampant in the summer. And again, I don't think the public are really tuned into that as well. So I think we've got to almost take an approach of, just because it's always happened here or there or whatever, I think people have just got to be a bit more accepting of, we're in a very fluid situation and things will change. So again, I think our goal will be to try and provide the most up-to-date, relevant information we can as quickly as we can.
Is there an action where we can kind of somehow try and bring together the COVID vaccine advice, the flu vaccine advice, and the RSV? I mean, there's no vaccine, but the fact that RSV will be harder this year. They're worried about it being harder this year because people have been shut inside, and obviously that's for the children, but then it's also for the over.
I think it's an ask we keep asking, but the problem is we have to wait until we're given something, and again it comes back to that much reduced comms team, who try as they might, you know, it's the smallest it's ever been, and so someone's got to change something. So I'd appeal to the NHS to get some comms helping quickly.
Fine, okay. Is that everything? Fine, well, thank you very much, everyone.
Thanks, everyone, and we caught up and finished on time.
And so do we have a date for our turkey and tinsel meeting, or whatever we call our December meeting?
It's unlikely to be turkey, it would appear.
December, but I haven't got a date just yet.
Fair enough.
And again, we're not sure. We might.
A pain with dates. That if I don't get a date in the diary, I'm just going to not be able to keep it free. Because
I'll work on it on Monday for you.
I'm sorry, I know I'm really difficult.
No, it's fine. I'll have a look on Monday for you.
And we'll have some thought to whether it's in person or not, depending on whether we can find a suitably aerated venue that will pass public health's guidance on ventilation.
Amanda, feel free to send me some dates that you got free in December.
Okay.
Yeah, we'll try and work around your diary.
I'll do that, Michelle. Thanks.
Thank you, everyone.
Well, thank you very much.
All right.
And
bye.
Happy weekend to you all.
Thank you. Bye.
Thank you, everyone.
Bye.
Bye.
Bye.